Good morning, everyone. We'll get started. I have no major announcements today, so we'll just go ahead and introduce our guest speaker. We're very fortunate to have the BC Cancer Agency and a very internationally renowned faculty, and particularly Dr. Tom Pickles, who's clinical professor at UBC and really a leader in the field of radiation oncology in the area of prostate cancer. So, Tom, why don't you enlighten us here this morning on what's new in radiation oncology?
Well, thank you, Larry. It's a pleasure to be here. And you've asked me every 2 or 3 years to come and tell you about updates. And I think this year we got some news for you about we do actually. Yeah. No. Well, wait and see. This is what I'm going to talk about. I want to update you about incidence rates and our projections for the future. I want to tell you about how things have changed for external beam radiation therapy, because what we're doing today is totally different from what we did 10 years ago. I want to give a different perspective on the outcomes of brachytherapy from that given by Peter Grimm a month ago. And I want to advertise a randomised trial which is about to open at VGH Prostate Centre and the Cancer Agency. So this is the incidence, the historical incidence going back 20 years of prostate cancer, and the axis is raw numbers of cases rather than an age standardised rate. And of course, as the population grows and as men get older in the population, the incidence is going up. And there are various blips that are largely as a result of PSA testing, which happened in the late 1980s. But interestingly, the incidence is relatively flat over the last few years. Now, on the right-hand scale here, I've got a different scale, and this is again number of patients, and what we're looking at is the utilization of by modality. So you can see that the radiation utilization really paralleled the incidence, and of course I chose the scale so that it would parallel it, but those curves are beginning to diverge. So, and that is for a number of reasons, which I'll talk about in a moment. Now, if we look at radical prostatectomy, it would appear that radical prostatectomy has become much more popular, which I think it has. I'm not convinced the data is accurate, though. This is from MSP codings of radical retropubic prostatectomy as the fee code. And I wonder if, particularly back in the 80s and early 90s, whether some of these may have been missing. So I think perhaps the incidence of or utilization of radical prostatectomy is perhaps higher in the 80s and early 90s than this graph might suggest. But it is interesting to see that radical prostatectomy and external beam are really neck and neck. Not that I think it should be regarded necessarily as a race. The new player on the block is brachytherapy, and I think if you add together the external beam and the brachytherapy, you can see that utilization of radiation is approximately flat. And another way of looking at this data is to look at the utilization as a percentage of the incidence. And once again, the utilization of radiation in either form is steady at about 35%. Now, Scott Tildesley, who is one of my colleagues across the street, has done a lot of work, starting in his fellowship in Kingston, looking at utilization rates and what should be the required or the optimum rate of utilization, and he looked at prostate cancer as well as other tumours. And we're right on target in terms of new patients. So we're treating about the right number of patients with radiotherapy, as you would expect based upon the evidence. Interestingly, however, we're not treating the right number of patients adjuvantly after surgery. We're actually below the recommendations, and that will be the focus of the very last few minutes of this talk. I don't know what the recommended utilization rates of surgery are. However, I did get an email from Tom Keane, who was my boss until he went to head cancer services in Ireland a few months ago. There, the use of radical prostatectomy is way down at about 15% of incidence. So he was asking me what the utilization was in BC, and I was able to tell him. So we are working with a company called Life at Risk, which is based in Toronto, and they have a product called Risk Analytica, which the Cancer Agency now have been collaborating with them, and we have built a model of prostate cancer in the province. It's a very complex model. It looks not just at incidence, but also disabilities and costs, and we can project out into the future likely scenarios, and this is a basic scenario of incidence into the future, and you can see that there are enormous ranges here. And these ranges represent the confidence intervals around our expectation, which is the red line in the middle. Now, for all of those of you who are residents, Clearly, there are going to be jobs for everybody. In fact, there are going to be shortages of oncologists and neurologists because all these guys with prostate cancer are just one reflection of urology, and whether it's benign disease or malignant disease, there's going to be work for everybody. Looking at this is again from Risk Analytica output here, looking at projections for prevalence over the next 25 years. And what this graph shows is that clearly the incidence is going to increase as the population grows and ages, but interestingly, the age structure of a man with prostate cancer doesn't really change. There's a slight, a year or two getting younger, but there's no shift, we believe, in the age structure of prostate cancer, unless, of course, we introduce a PSA screening program, which we can model and have modeled in this software, but I'm not going to show you today. Okay, so on to external beam radiation therapy. Radiation is getting better, and this is a multivariate analysis-generated curve which is meant to take into account differences in Gleason stage and T stage and radiation dose and so on over the years. But actually, everybody here, I think, will realize that there has been within stage shift and within Gleason shift over the last 10 years, and I'm not convinced that better radiation is the sole result of these better results. But here we have a real improvement anyway in terms of the biochemical control rate. And I'm going to explain why I think better radiation techniques are at least some of the reason for this. So in the late 1980s, we moved from what is still called conventional simulation, which I'll describe in a minute, through 2.5-dimensional planning, through 3D conformal radiation therapy. In this decade, IMRT has become mainstream in many centres, and I'm going to tell you about what we're doing currently with image-guided radiation therapy, and tell you about a new development called VMAT. So this is what we did in the 1980s. We took orthogonal X-ray views of the pelvis, and we used a urethrogram to identify the prostatic apex, and we used our clinical knowledge of the size of the prostate from DRE, and we put on a square box, and we hoped the prostate was in the middle of that square box. It wasn't quite that crude because we also sometimes used rectal barium to help localize the rectum. And then in the corner, we introduced a little bit of does this work? Maybe I can use the mouse. In the corner, we used a little bit of shielding, which was an attempt to minimize rectal toxicity, but the sort of dose of radiation we could safely give was limited to 66 gray, and that for many years was a standard dose of radiation. Oh, thank you, Mary. We moved to CT-planned treatment in the early 1990s. And what we did was we did a CT scan and we identified in the middle of the prostate where it was, and we contoured the prostate gland on all the slices, but the radiation planning didn't really take into account the changing configuration of the shape of the body, and nor did it take into account the fact that the hips are quite dense and other soft tissues attenuate the radiation beam differently. So this wasn't really proper three-dimensional conformal radiation therapy, and we were able to give slightly higher doses of radiation of about 70 gray. What we're doing these days is conformal radiation therapy, and this is really a dated picture looking at the dress of a linear accelerator, and the linear accelerator can rotate to deliver the radiation at 2 or 3 fixed angles. And in the head of the machine, we have what's called a multi-leaf collimator. You start off with a square opening, and then these leaves of lead-like material move in and out to shape the radiation beam. And each of these leaves is driven by a little motor here. You want a motor which is very reliable and can work many, many times and quickly. And they actually, our machinery is made by a Swedish company, and they actually use windscreen wiper motors from Volvo cars because they're the most reliable. So this increased dose that we can give has been shown in a number of studies to lead to improved outcomes. I chose this particular study not because it's the best, because it's actually, what they did was they randomized patients to conventional dose radiation with a conventional technique to a 3D conformal dose and a 3D formal technique. And so what it actually did was it didn't just increase the dose from 70 to 78 gray. and incidentally showed a considerable advantage in terms of biochemical control rate and subsequently metastasis-free rate, at least for the intermediate risk cancers, but it also, I think, showed that it was the combination of increased dose and better technique which led to improved outcomes. And I won't go into the reasons why some other studies also support that. But this came at a cost of increased toxicity. So the rectal toxicity was quite high. The grade 3 or 4 toxicity is toxicity which is more than a nuisance and which needs intervention. And so this came at a price, and with radiation you can't just keep increasing the dosage without increased toxicity unless you change the technique and improve it better than we had done here. So in the late 1990s we moved to true three-dimensional conformal radiation, and what this means is that the radiation dose is computed taking into account the 3 dimensions of the whole CT volume by the computer, and this allows us to use the multi-leaf collimator to conform tightly around the prostate gland on seminal vesicles with appropriate margins, and allows us to increase the dose further to around about 76 gray. Does this lead to better outcomes? Well, I think it probably does, and we had an opportunity when we opened the Surrey Clinic, I think, to explore this. What happened was the Surrey Clinic was built in the mid-1990s, early 1990s, but the staff for the Surrey Clinic came on staff in Vancouver for about a year beforehand and started seeing patients from Surrey in Vancouver and treated them in Vancouver, and then when the Surrey Clinic opened, they just moved their patients and themselves to work in Surrey. So they'd been working in Vancouver for the best part of a year, and we were all treating patients the same old-fashioned way. But then they went to Surrey, they had new equipment, and they had the ability to use 3D conformal radiation therapy for about 9 months before we did in Vancouver. So we thought this is an opportunity to look at the outcomes of these guys. So we took this 9 months worth of patients, and using same selection criteria and the same dose of radiation therapy, we looked at the outcomes, and we found that the 3-dimensional group in Surrey were doing slightly better, but not really significant, marginally, than the 2-dimensional group. And this came actually without any increased risk of toxicity because the dose was the same, but the technique was better. So here we have the grading of toxicity. Actually, I'll go through this because we're going to talk about it later. Grade 1 is just a minor side effect, not requiring any intervention and really just a nuisance, if that. Grade 2 is something like requiring terazosin or maybe a steroid suppository for radiation proctitis. Grade 3 requires a surgical intervention like a dilatation or minor surgical procedure, argon coagulation for rectal bleeding, laser coagulation possibly, and grade 4 toxicity is life-threatening like a colostomy, and grade 5 is fatal. So this was accompanied without an increase in toxicity. But we've improved since then. We moved to IMRT. Well, we did and we didn't. We don't use IMRT routinely for prostate cancer, and I might go into that, but it can be used for prostate cancer, and it's certainly used for other malignant diseases. What this does is it uses many fixed beams of radiation therapy, in this example 5, and each beam is modulated by using this multi-leaf collimator, not, as you would expect, to conform exactly to the shape of the prostate, but it's used in an analogous way to the stealth fighter. The stealth bomber does not look like it could fly because it doesn't logically look like a plane that could fly. And if you look at each of these 5 beams, the shape of the multi-leaf collimator pattern does not make sense, but if you deliver the radiation therapy, it delivers a very tight, homogeneous dose to the target. So I want to compare the techniques we've used and look at the toxicity. Here we have a standard, what we call a 4-field arrangement that was used in the 1990s, and you can see in red the target, which is the prostate, and around that we have a green box, which is what we call the 95% isodose, and that basically defines the high-dose region. But what we don't tell you is that there are large areas that get 50% of the prescribed dose. Now, 50% of 70 gray is actually not very much in terms of the biological effect, but if you treat a large volume of the rectum, as we are here, then it contributes markedly to the toxicity. And the hips get a significant dose, but the hips, you don't usually get any side effects. But look at the orange area, it's quite a large amount. If we use IMRT, where we're using these 5 static beams, you can see that the orange area is somewhat less, but Perhaps more importantly, in the rectal region, there's good rectal sparing, and the rectum is one of those areas, along with the bladder, which gives us most of the side effects. Now, I want to tell you about a new technique called VMAT. For many years, we have wanted, or the community at large has wanted to improve on IMRT, and the algorithm that Carl Otto, one of our physicists, cracked is the ability to use rotation of the beam in so the delivery, the radiation is delivered whilst the beam of radiation is rotating around the patient. Now, we can rotate the beam around the patient ordinarily. That's not the clever thing. The clever thing is that the MLC pattern is constantly changing, and it delivers those 5 or 6 static IMRT beams in a single sweep. This has 2 big advantages. One, the treatment time is a minute as opposed to 10 minutes. But secondly, the amount of scattered radiation is much less, and I'll come on to that in a moment. So what we do is I'm going to show you his head and neck cancer. So in the bottom right, we have a head and neck CT scan, and we have a tumor which starts here and goes all. It's an oropharyngeal tumor. It goes all the way, or base of tongue. It goes all the way around the airway, and the critical organs here are the spinal canal, which we do not want to give high dose to, and the parotid glands. If we give a high dose to the parotid glands, the patient ends up with a dry mouth, which can be quite debilitating, but if we give a very high dose to the spinal canal, the patient will die. And in the top, we have the MLC pattern, which doesn't make sense to me. It does not look like a round shape around a tumor. And here we have the radiation profile that is being delivered by the MLC. And what we're going to see when I animate this is the build-up of the radiation dose as this rotates. So, as this rotates, we start to see here the build-up of a complex radiation shape, which is not something which we could accomplish with standard radiation, and would be very difficult to accomplish with IMRT without giving a high scattered dose of radiation and taking a long time. So Carl is a brilliant guy, and he sold this invention to Varian, whose share price went up 25% at the same time as everybody else was falling. So this is now just coming out into the clinic, and we're one of the first people to be able to explore this, and we are doing so in prostate cancer. Now, so what we can accomplish with this VMAT technique is a reduced high-dose region compared with the IMRT. And we think we can push the dose up to around about 86 gray. One of the problems is the prostate moves. Should I slip a slide? No. The prostate moves, and this is one of the things we prefer not to think about, because if you're using very focal treatments and the prostate moves 5 millimeters or even 10 millimeters, then you have a problem. And this problem is worse in the obese, and it's worse in those who have a lot of gas in their rectum. And this is a small study that was done in the US, where they looked at people who had a lot of gas in their rectum, and they found that the biochemical control rate was much worse. In fact, it was atrocious. So we need to address this issue, and what we've done and are doing now routinely is putting 3 marker seeds, fiducial markers in the prostate, little gold seeds which act as a marker of where the prostate is each day. So each day, just as the patient is about to be treated, the linear accelerator takes a picture of where these marker seeds are. And it compares. On the left here, this is a digitally reconstructed radiograph from the CT scan of the position of these 3 in relation to the radiation portal. And here is a megavoltage image taken immediately prior to treatment. And as you can see, there is a mismatch here of a few millimeters between the calculated edge of the radiation beam and the edge as envisaged. And the software just moves the patient, in this case, by 6 millimeters. And this makes the treatment apparently more accurate. And unusually in radiation, we think it'll increase both the cure rate and decrease the toxicity. And usually those two go in opposite directions, go in the same directions. But this complexity comes with a price, and the price is potential errors. Of course, we take a lot of care to ensure there aren't errors, but in fact the error rate has gone down as the technology has improved. It diverts resources. It can take hours to plan a VMAT plan. It can take an hour or 2 to plan an IMRT plan, and it can take 20 minutes to do a conventional 3D plan. So it has an impact on waiting lists too. If the treatment takes a long time, it's going to push up the waiting lists. And it costs money, therefore. These are the costs approximately of brachytherapy, external beam and IMRT, and open radical prostatectomy. And you can see that IMRT is getting expensive, and in the United States it's really expensive. In fact, open prostatectomy looks like a good deal at the moment, but I guess the robot's a little bit more expensive. If you look at the cost in a different way and look at the benefit and the quality of life year adjusted benefit, then the cost really is very expensive and really getting up there to a point where is it worth $48,000 per quality adjusted life year for IMRT? And then this is one of the two dark secrets of radiation oncology that I'm going to tell you about. Second malignancy. Cancers can be induced by radiation. Now for prostate cancer it is not straightforward. Firstly, let me say, and you can tell your patients this, having prostate cancer is not necessarily a bad thing, because if you look at the life expectancy of a man diagnosed with prostate cancer, it is actually greater than the age-matched population without prostate cancer. And this is interesting, and it may be that you just, to get prostate cancer, you live to be 70 years old and you haven't already died of heart disease and everything else, but perhaps there's more to it than this, and it could be that there's some genetic reason why people who have prostate cancer do not get other diseases so much. So, overall, the life expectancy is greater than the general population, and the risk of other cancers, generally in prostate cancer patients, is less. But some patients who have prostate cancer have an increase. There are some cancers that are increased risk, and these are bladder and testis. And the almost certain reason is that to have an early bladder cancer diagnosed, you have to see a urologist, and if you're seeing a urologist for prostate cancer, it is perhaps more likely that you might have a urine analysis or mention a symptom or have a cystoscopy and have an early bladder cancer diagnosed. And the same for the risk of testis cancers. I suspect that this data comes from orchiectomy for metastatic disease and incidental findings of tumours at the time of orchiectomy, or it could just be increased presentation or something else. But if you give radiation therapy to a man with prostate cancer, there have been probably an increased risk of colorectal cancer because the rectum is right next to the prostate. It gets a high dose of radiotherapy. The risk is small. It has been estimated as increasing from 0.25% increasing to 0.5% in one study. Another study showed nothing. And just yesterday there was a big study published from SEER. It's only online, and I only read it last night, and actually it shows the risk of inducing a cancer is 0.16%, which is much less than the 1 in 220 risk, which our research here showed. So the risk is there, but it's for most people it's not enough, I think, to persuade them not to have radiotherapy. The exception probably is the very young people in their 40s and early 50s. Jeremy, you've got a question.
How do you tell if the cancer is being induced by radiotherapy?
So the question was, how do you tell if the cancer has been induced by radiation? And the answer is, in one individual case, you don't know. But what you can do from a population study is look at the rate in people who have radical prostatectomy and compare them against those who had radiotherapy, for example. And that's how this study was done. Okay, I want to move on to the other big advance in radiation for prostate cancer in the last decade, and that has been our understanding of hormone therapy or androgen deprivation therapy. And here are high-risk outcomes across the street by era. So as we moved from relatively small use of hormone therapy, 45% of patients... I'm sorry, this is the BMED rate. The BMED rate improved dramatically as we increased our utilization of hormones with the publication of the bolus study in abstract form in 96, 97. It jumped up, and with that, the results improved dramatically. So the bolus study here, top left, was just one of a number of studies, randomized studies, which have shown survival benefits. Some showed a bigger benefit than others. The bolus study showed a halving of the death rate from the use of 3 years of hormone therapy versus none. The BOLA-2 study, only out in abstract form so far, shows that the use of 3 years versus 6 months led to a 25% reduction in the chance of dying. And there are other studies which showed lesser benefits from shorter durations of hormone therapy. And something really special is going on, and this is the 8610 trial. This was just a recent update of this old study started 20 years ago. And the point I want to make is this: that these guys got 4 months of hormone therapy a decade earlier. And that translated into a 9% absolute survival improvement, which is dramatic. If you think of women with breast cancer getting multi-agent chemotherapy for months for 2% survival advantage, here we have a simple drug, 4 months, given 10 years earlier, leads to basically a 10% survival advantage. And that is remarkable. Now, I mean, the result, this is overall survival, and obviously everybody dies eventually, but I think this is quite impressive. And it tells us that something special is going on. And what is going on is, I think there are 3 ways that the hormone therapy is interacting beneficially with radiotherapy, which, of course, it doesn't with surgery. As you know, the trials with surgery have been negative. This is Mike Milosevic's work from Princess Margaret Hospital. He did oxygen measurements using an Eppendorf probe of the prostate. What he found was, this is the pre-treatment oxygen levels in the tissue. This is the post-treatment after a couple of months of hormone therapy. This is the line of equivalence, and most of the cases, the dark ones, are statistically significant. These have improved oxygenation as the tumour shrinks with hormone therapy. Now, why is that important? Because radiation is the harmful effect of radiation against DNA in the cancer cell is fixed and made permanent by the presence of oxygen. And if you don't have oxygen present, within a nanosecond, the damage doesn't occur. The free radicals are mopped up. And Anthony Zeitman showed this also. He showed that if you use radiotherapy alone, you needed, to get 50% tumour kill, you needed 80 gray, but if you castrated the animal after radiation therapy, you only needed 60 gray, and if you castrated the animal before radiation, you only needed 40 gray. So he showed clearly in a tumour model that this was a radiosensitizer. So we think it works by reducing the tumour volume, by reducing tumour hypoxia. It also increases apoptosis, although this is thought to be a minor mechanism. And interestingly, it affects the immune system such that it can reduce the recurrence of cancer outside the radiation field at distant sites. And some of this work has been done in Victoria. So, does it matter whether you give the hormone therapy prior to radiation or after radiation? Well, Anthony Zeitman's work would suggest you get a bigger bang by giving the hormone therapy prior to the radiotherapy and during the radiotherapy. And our data here doesn't actually support that. In a multivariate analysis, whether the timing of the radiation of the hormone therapy was not significant, it was a complex analysis to do because those who had neoadjuvant and concurrent and adjuvant hormone therapy had much longer hormone therapy than those who just had pure neoadjuvant therapy. But our attempts in a multivariate analysis to untangle this did not show any clear evidence that it was the timing of the hormone therapy. We published this a few years ago, and I just updated it last week to see if it still held true. It's the duration which matters. Well, we have a randomised trial, and this is a remarkable study because you really can't get to survival curves closer than that. So this was 4 months given, well, actually it was 2 months neoadjuvant and 2 months concurrent with radiation versus 4 months pure adjuvant. Absolutely no difference. So I think the timing is unimportant. I think it's the duration of hormone therapy which is important. And it's not due to permanent castration. Some people wonder if we give hormone therapy for 3 years, whether we just castrate people forever. Well, the answer is no, we don't. This is from our work here, published a few years ago, looking at testosterone recovery to 50% of normal, or nominally normal. Elderly people actually have testosterone less than 10, and we found that 83% of patients had testosterone recovery, most of them within the first year. And I updated this looking at our brachytherapy database just last week, and because these guys are younger, I think, the testosterone recovery is faster and is actually fully complete. So that effect from the 8610 trial a decade earlier is not due to hypogonadism. But hormone therapy has a lot of side effects. It has ones that I could describe as a nuisance, and the patient may find it more than a nuisance. But it also has serious toxicity, which has only really become apparent in the last 18 months with metabolic syndrome, with weight gain, increased risk of diabetes, heart disease, and actually an increased risk of dying. And I tell patients now that for every year they're on the drug, there is a 1 in 500 chance of dying where they would not otherwise have done so, which is not a big risk, but dying is a pretty serious side effect. So how much hormone therapy do men need? Because the randomized trials would suggest, one trial said lifelong, one said 3 years, one said 2 years, one said 6 months, and some patients may decide they don't want any hormone therapy at all. And this is the big question we're asked with high-risk cancer every day in the clinic. Is, do I really need my hormone therapy for 3 years, doctor? So we've been looking at this in conjunction with a group at the Peter Mac in Melbourne. We have a multi-clinic study of nearly 4,000 cases from 4 centres, Peter Mac, ourselves, Fox Chase, and William Beaumont Hospital, and we use some complex proportional hazard modelling to end up with a curve like this. Now this is the hazard ratio of relapse, and we start off at a hazard ratio of 1 with no hormone therapy, and we end out here with 3 years of hormone therapy. If you take hormone therapy on the patients that we treated in this multivariate model, then you end up with a hazard ratio of about 0.2 for biochemical relapse. And what we're able to do with this is we're able to look at how the proportionate improvement in an outcome according to duration of hormone therapy. So compared with 3 years of hormone therapy, 6 months gives about half of the total potential benefit, a year gives 83%, and 2 years 96%. And I think this is very useful, because you can say to the patient, okay, well, maybe you don't need 3 years, maybe you don't need 2 years, but maybe you could do better than 1 year. And interestingly, if you look at the patients we have treated, the median duration of hormone therapy of high-risk cancer is actually 18 months, which is quite fortuitous, because it just seems to be exactly where I would say you begin to get that balance of risk and benefit. Now, this is a multivariate model for everybody, but clearly some people have higher risk cancers and other people have lower risk cancers, and different radiation doses interplay in this. And so at the moment we're developing a nomogram which will allow an individualized output, which I think will be slightly more useful. So I've talked about the benefit of hormone therapy, but not everybody does benefit in terms of biochemical control. Here we have the NCCN risk groups. Low risk have no benefit. Intermediate risk do appear to have a benefit, and high risk have a definite benefit, which has been shown in randomized trials. But there's very little data on intermediate risk prostate cancer. So what we did with a fellow who was with us a couple of years ago was we looked at the intermediate risk group and we said, can we find out more about this intermediate risk group? Because it looks like they benefit from hormone therapy, but within that intermediate risk group there's a spectrum, and maybe the guys with low intermediate don't need hormone therapy, and maybe the guys with high intermediate do. And that's exactly what we found. So we found that if you had a PSA up to 15, as long as you had Gleason 6, if you had if you had a Gleason 7, or if you had a PSA above 15 with Gleason 6, then you benefited from hormone therapy. Whereas if you had this low intermediate risk, you didn't appear to benefit from hormone therapy. So this has helped us in the clinic and is actually basically what we do. Our treatment algorithm takes the intermediate risk group and divides it in half, and has done for the last decade, and we treat the worst half with hormone therapy and the better half without hormone therapy. So using the more modern doses, the better use of hormone therapy, these are patients treated in 2000 and 2001, just actually a year's worth of patients. I couldn't look more recently because we don't have the follow-up. So actually, I think we're doing better than we did in 2000 because we didn't have the IMRT and everything. And these are the sort of results that I think you should expect today, categorized by risk group. And this is rounds that were given here by Rod Sturden. One of the nice things about having this on the web is that you can go and you can grab the slides off and put them in your own presentation. So, and I don't want to make a big play of this, but just to say that I think our results with high-risk cancer are really very good. And I attempted to match what I could in terms of the duration of hormone therapy and the follow-up and so forth. And I think that high-risk prostate cancer treated surgically is fine for very selected patients, perhaps with just T1 disease who have Gleason 8, Gleason 9 disease, but not with the PSAs of 20 and T3 disease. And we're still seeing guys like that who come back having failed. Okay, so let's move on to brachytherapy. Brachytherapy is attractive because we can give very high doses of radiotherapy. It's very focal, so we don't worry about prostate movement because the seeds are in the prostate. We can have a margin of treatment which is enough to cover microscopic extension in the majority of cases. And there's something peculiar about low-dose rate continuous radiation which has radiobiological advantages which are not fully understood. We don't really know how brachytherapy compares with external beam or with surgery because there are no randomized data, and attempts at doing randomized data have failed. Studies have failed to accrue. Now, Peter Grimm was here, and he showed slides like this, and I think there was some misunderstanding, and I'm going to go through them in a different way. Firstly, these numbers refer to the publications. So each of these is a reference, and on the notes view of the PowerPoint presentation, I have all the references. And of course, they're all over the place. So this is time, and this is the biochemical control rate. But the problem is this. There is a bias. This is the second dark secret of radiation. There is a bias in favor of radiation when we look at outcomes. It's to do with the fact with radiation you have to wait for the patient to respond and achieve a nadir and then relapse from that nadir before you score a relapse, whereas a guy with surgery is at risk of relapse from day one. So there's a bias which is approximately 10% in favor of radiation. So what I'm going to do is I'm going to shift all these surgical points up by 10 to 15% because I think it's a fairer comparison. And for low-risk prostate cancer, when I add the results of brachytherapy, I really don't think, I mean, they're all over the place, right? But I don't think any of us could really say that one treatment looked better. And these are not randomized comparisons anyways. So it's very similar. But when we get to intermediate risk, I think we're beginning to see something else. Here, I think we're beginning to see some series which have apparently better outcomes. And that's what I'm seeing in the clinic, particularly in comparison with external beam radiation therapy, which is down here. Because I was a cynic when brachytherapy started, and I did not start treating patients in 1998. I waited until I had a sabbatical and I could learn the technique 3 years later. And in the clinic, we get our PSAs faxed to us while the patient is there, and I'm sometimes waiting by the fax machine, and I was there waiting, and my PSA results would come in on patients 0.8, 1.3, and Jim Morris's would come in 0.04, 0.1, 0.02, and his patients had been treated with brachytherapy, and I really began to wonder, and I saw it in the clinic. Actually, I've got 250 patients I've treated myself, and only 3 have relapsed. So. Anyway, our program, we're very proud of it because it's 10 years old this summer. We've treated over 2,200 patients, and from day one we've collected data. And we are just in the process of publishing the outcomes of the first consecutive patients from patient 1 to 1,006, with a minimum 4 years follow-up. And we treat the low-risk and the low-tier intermediate risk, those who do not need hormone therapy. But when we were starting out, we were a bit cautious and we wanted to use hormone therapy, which we've recently dropped. And here the biochemical control rates, 95, 96%, no difference according to risk group. And these are remarkably good results. We've had 5 patients with metastases. We've had 54 non-prostate cancer deaths, which is pretty good. I think it means that we're choosing our patients appropriately with a good life expectancy. We've had 1 death from prostate cancer and 1 complication. A patient with obstruction didn't present and ended up getting renal failure and sepsis. And treatment comes usually at a cost of toxicity, and this is one way of looking at toxicity. This is the prevalence rate of GU toxicity in the years. So this is year 1 to 2, 3 to 4, 5 to 6 after treatment. And you can see that there is significant toxicity, but most of it is low-grade nuisance side effects. But medication is required by about 20% of people for 2 or 3 years after brachytherapy. There is a small percentage, 5% or so, of patients who have ongoing long-term toxicity. And that's higher than I would like to see, and our main focus of the program now is to decrease the toxicity whilst maintaining these high control rates. Acute urinary retention is the major toxicity that we see, and it usually occurs early after brachytherapy within the first few weeks. The chance long-term is really very minuscule. This is the urinary retention rate according to our learning curve. These are cohorts of patients from patient number 1 up to the most recent, and you can see that our acute urinary retention rates have improved. Now, and it took 400 patients for it really to fall. And looking at this, I think, unlike this curve, I think what actually happened was there was this era, and then there was this era. Actually, I started just here, but I think that's pure coincidence, because what happened when I started was we changed We used to use about 40 or 50 needles per case, and we moved to about 30 needles per case, and I think this was what it was. It was the trauma from inserting 50 needles into the prostate which caused swelling. And this is the GI toxicity, very much lower than the GU toxicity, with virtually no long-term side effects. We've had 3 colostomies out of the 2,000 patients that we've treated, which is less than the colostomy rate at radical prostatectomy, I'm told. Potency depends who you ask. We published this, we asked the patient and we asked the doctor if the patient was potent, and unsurprisingly the doctors thought the patient was potent more often than the patient thought that they were potent, but nonetheless there were substantial numbers of patients who had preservation of potency, and a number of studies have shown exactly the same thing, but the chance of preservation of potency by and large is best with brachytherapy compared with other treatments. So my bias in the clinic is that brachytherapy patients were doing better, but I wanted to try and prove this, so we did a matched pair analysis, choosing patients treated in exactly the same era, same couple of years, with exactly the same PSA, with the same duration of hormone therapy if it was used, with exactly the same Gleason score, the similar percent positive cause, the same T-stage, in other words, all the known prognostic factors that we could identify. And we ended up with matches for 139 patients treated with brachytherapy and 139 treated with external beam, and of course no difference because of the matching in these groups. And what we found overall was that there was 95% 7-year projected biochemical control rate with brachytherapy and 75% with external beam. So I genuinely feel that for selected patients we're getting better results with brachytherapy, and that's now been reflected in the clinic because now we're treating about 50% more patients with brachytherapy than we were a couple of years ago. The other interesting thing is here, if you look at those who relapsed, look at the PSA doubling time. In those who relapsed with external beam radiation, there was a slow PSA doubling time, which implies local recurrence or failure of the primary treatment. In those few who relapsed with brachytherapy, the doubling time was fast, which indicates that they likely have metastatic disease. And the implication to me is that they probably had metastases at the time of treatment, occult metastatic disease. The other thing which bodes very well for the future is look at the last PSA, recordable. Just like I said in the clinic, the guys with external beam, a lot of these are going to fail in the future. These guys are doing really well. There's no Canadian published outcomes really that I can find. There's none from VGH, but here we have the Canadian 3 versus 8 month study by risk group. And what it shows is, I think, results which, depending on the patient group, are well, here for 5-year biochemical control rate is about 75% for low risk. But this is Canadian data, not VGH data, and I believe VGH data is better. Okay, in the last 5 minutes, I want to talk about post-operative adjuvant radiation therapy, because this is the area where I believe we're not treating the right number of patients according to national and international guidelines, and we have a randomised study which will allow every post-operative patient to get radiation therapy, or at least be studied. So from that Canadian study I showed you, 24% of patients had positive margins, and having a positive margin puts you at risk of relapse. And so here we have patients from an international trial who had a positive margin and didn't have any additional treatment, and you can see that the median time to relapse is about 3 to 4 years. So a positive margin is not a good feature, and it occurs in about 25% of patients treated with surgery. But if you give the margin-positive patients radiation therapy, then their biochemical control rate approaches that of those who did not have a positive margin. So here we have a factor which can be identified the day after surgery, which leads to a halving in the recurrence rate. And there are 3 randomized trials which show that. The hazard rate, 50%, 51%, 40%. From these 3 randomized trials from adjuvant postoperative radiation therapy. And this is a phase 2 study, unpublished, but showing the outcomes of adjuvant radiation therapy compared with salvage radiotherapy. Salvage radiotherapy being if you wait until the PSA is going up to quite high levels, maybe 1 or 2, and then you give the radiotherapy, and these people do really badly. In fact, I don't think anybody's cured, whereas the optimists would say that this curve is flattening out. Or maybe you could use hormone therapy, and I know a lot of patients here who have an early relapse after surgery get hormone therapy, but we have to be careful because there's no level 1 evidence, and in fact the evidence that is there with adjuvant bicalutamide showed increased death rates from the hormone therapy, and it was taken off the market with this indication. So we have a trial. It's a complicated trial. Everybody who has a radical prostatectomy is potentially eligible. If you as the surgeon are uncertain whether this patient, because of adverse features like a positive margin, needs radiotherapy or not, and you're uncertain, then you can randomize that patient to immediate radiotherapy, or you can choose to monitor that patient in the clinic. If they're randomized to, if you want to put them through the randomization, if you want them to have radiotherapy, they get randomized to hormone therapy in 3 different arms. If, however, you don't want to treat them, you monitor them, and if the PSA starts to go up, then they get randomized to 3 different durations of hormone therapy, having had radiotherapy. On the other hand, if you are convinced, because he's a young guy and he has extensive positive margins, that you want to give him radiotherapy, you can assign him to radiotherapy, and then he is randomized to different durations of hormone therapy, or none at all. And again, if you're not sure, you monitor the patient, and subsequently he gets radiotherapy or not. So this is a complicated trial. It's a big trial, a couple of 4,000 patients, and it is opening jointly VGH and at the Cancer Agency. And because these patients are identified by you as surgeons, we really ask for your help in accruing to this trial. It's being run from the UK, from the Medical Research Council, and it's a typical UK trial in that it's very permissive. You can choose which arm to assign patients to for the first group, or he can be randomized. And then there's this subsequent secondary randomization. So really there is no excuse for not putting patients into this trial. And the outcomes are cause-specific survival and quality of life and so forth. So that wraps up my 45 minutes, but I hope I've given you an eye into what we're doing across the street, and I would mention that you're very welcome as residents or students to come across and join us in the clinic and actually see some of the machines, because I think if you see it, you'll get a better appreciation than the pictures have shown. And we have clinic on a Thursday afternoon and other times, so just contact me or one of my colleagues or the chief resident, Dave Palmer, and we can arrange something for you. Thank you.